This is an elderly gentleman with a relatively non-dilating pupil, pseudoexfoliation, and what seems to be a tonic pupil. So after making the incision, staining the capsule with trypan blue, I go ahead, express out the trypan blue and the air bubble with 2% HPMC, after which I go ahead and fashion my 5 mm rexus. And this pupil is more than adequate for this rexus. Just using the pupillary margin as a guide, I go ahead and fashion my rexus with the bent 26 gauge needle. The cataract, though mature, is not intumescent, so there is no fear of any Argentinian flag developing. However, there is pseudoexfoliation in this case, so we have to be a bit worried about the zonular integrity. So once the rexus has been done, I go ahead under the capsular rim and do my hydrodissection, and you could see the lens coming forward, and that's more than enough. So I put in some chondroitin sulfate as well, and I am good to go. So I am planning to do the direct chops, and from here onwards it's completely unedited, just for you to appreciate all the surgical steps. So this is the woodcutter's chopping technique, and this is a small pupil, but more than an adequate pupil to carry out these procedures. The problem with these pupils is they keep getting smaller as you go along. So these chops have to be complete. You cannot have half-hearted chops. It has to be complete, it has to be all the way through, and the backbone should be broken as far as possible. So I am planning to make at least 4, if not more, chops, but 4 should be enough. And you can see I am going at different levels and making sure the entire chop is carried through. The crack should be propagated all along the backbone. So I have got 4, although the 4th piece is slightly big. Doesn't matter. Got out the central disc as well, and there's that slightly big piece, but doesn't matter. It cracks and very easily it's emulsified and eaten. And watch my phaco tip. I am staying within that center of the pupil, not going towards the pupillary margin. I manipulate the segment into the center, get it into my phaco tip. My phaco tip is turned posteriorly and go on eating away, except for this last piece which has migrated behind my tip. I had to come and bring it to the center and then eat it up. Just cleaning up that paracentesis wound, and that's done. And this is again not edited, and you will see how difficult it was to remove this cortex. You can use your irrigation tip to move the iris away. However, I am trying my best not to do that, because it's only going to stimulate the iris more and more. I am seeing if I can remove all this cortical epinuclear sheet without touching that pupillary margin. I did touch it once, but let's hope I don't do it again. I do turn my aspiration tip posteriorly now and then, but I would advise you to avoid that maneuver as far as possible. Instead of that, it's better to switch hands and then get the cortical sheets. So here still there is a large epinuclear sheet there, and I've got to get under it, trying to grab enough of it into my aspiration tip. There I got that. I manipulate my irrigation under it so that it presents itself to the aspiration port, and that's it. Most of it is done. There's still quite a bit, and that should be done. Now In the meantime, look what has happened. Since I have made my side port through the pterygium, now the fluid is egressed under the conjunctiva, and there is conjunctival ballooning, which is making my life more difficult because, and of course my assistant is going on irrigating as well, so I am basically operating in a well right now. At this point I have just cleaned up the posterior capsule, and before I implant the intraocular lens I decide I have to handle this ballooning. And see, this is how I do it. I just make a nick into the conjunctiva and towards at the limbus, and this one is a pre-existing opening which I extended, and then taking my dialer I just sweep, applying pressure on the sclera and sweep that fluid towards that opening that I have made, and see how beautifully the fluid comes out. So this is one way to handle the conjunctival ballooning that you get. These small nicks that you make will heal in no time. You don't have to worry. Finally, I am injecting my single piece hydrophilic lens directly into the bag under HPMC, of course. I then remove the HPMC with my Simcoe cannula, put in my intracameral antibiotic, and I conclude my surgery. Thank you so much for watching.